prevention is better than cure, because as we know, there's no cure for dementia. It is basically healthy living is healthy aging, I would say. Social isolation, not only for dementia per se, but for depression as well. And depression indirectly puts you at a higher risk of dementia. We are heading towards what we call as a silver tsunami. The REM sleep is the most important as far as memory and cognition goes, because all the cleansing of the brain happens at that time.
Welcome to the Ivory Podcast. My guest today is Dr. Santosh Bangar. Dr. Santosh is a senior consultant geriatric psychiatrist and neuropsychiatrist with over 22 years of rich experience in working with senior citizens. He specializes in dealing with memory problems, dementia, depression, sleep apnea, and even conditions like stroke, epilepsy, and the Tourette syndrome. Dr. Santosh, welcome to the Ivory Pod.
Thank you.
We want to begin by asking you if dementia only affects older people, or are people in their 40s and 50s could be at risk too?
Yeah, it's a very good point. Because see, a lot of people know that dementia is exclusively illness of old age, or people over 65 get dementia, but that's not the case. So we do have what we call as young onset dementia, so YOD, and in that also Alzheimer's is the commonest. So it's not exclusively seniors or older people, even younger people are at risk, and that happens when it runs in the family. So the hereditary component can start as early as 30s and 40s also.
Okay, so that's an interesting one, because I think research on this is still developing. Could you elaborate a little bit about what role do genetics play in dementia?
So fortunately, most of these dementias are not hereditary, but when they do, they can affect people, as I said, in the early 30s or 40s. So Alzheimer's can run in families, so can Parkinson's disease. And when it happens, affects the brain, it can cause Parkinson's disease, dementia, all the cognitive impairments. And frontotemporal dementia, or FTD, that can also be hereditary. So these are the three common ones we see in clinical practice. And what it does is, as we know, these dementia it's a broad term. Basically, it's not a diagnosis on its own. So what it means is affection of the whole brain function, so the impairment. And classically, or the commonest, is the memory, because that's the one earliest symptom that we know about. But it also affects language ability, conversation, communication, organization, planning, so on and so forth. So all the brain functions are affected. And there are several diseases which can cause dementia. So dementia per se is a syndrome. What that means is a combination of signs and symptoms. So Alzheimer's disease is the commonest one, which people know and hear about. And when it causes dementia, it's called Alzheimer's disease dementia, or Alzheimer's dementia for short. So that's the basic difference. Then there's something called vascular dementia, or as the name suggests, vascular, pertaining to the blood supply. So anybody who's had stroke or blood pressure for several years, they are prone to get dementia, and that can be vascular dementia or a mixed dementia. So when there's a combination with Alzheimer's or Parkinson's, so it's called a mixed dementia. And as we know, certain vascular illnesses or diseases are hereditary too. So if you were to extrapolate that, then that will also come under the hereditary component of the dementia, vascular dementia.
Got it. You used a word called impairment. Somebody who is watching this is hearing this word for the first time.
Yeah.
How would you explain this term to a layman?
See, impairment per se, we have day-to-day occurrences, like we go to a room and we don't know, why did I come there for, or I need a book or something like that. So that's a one-off. But if it happens over and over time and period consistently, and it's a progressive, then we call it as impairment, and it affects the day-to-day ability. So forgetting to pay the bills, for example, or not switching the gas off. So that is when we take this very seriously. So not one-off, forgetting things, or when you're under stress or not had a good night's sleep or whatever, we do forget. So forgetfulness is not equal to dementia. That's what we should, understand over here.
Let's take that a step ahead. If forgetfulness is not equal to dementia, What are some of the telltale signs of people who come to you? When do you exactly know that this is a patient who is probably more cognitively impaired than somebody else?
Yeah, so that's a great question because people sometimes they come to us much later on, when most of the damage has already happened, and it's probably too late to intervene, or the intervention to show effects. So people, early on in the illness, or when they realize is forgetfulness or short-term memory. So you forget what happened few minutes ago. Say by 10 o'clock you've forgotten if you had breakfast, what you ate for the breakfast. Those sort of things. And this is a pattern. It happens over a period of time, and it progresses with time. So that's one. Short-term memory loss, because people know, and it's very common, to see somebody who's having short-term memory loss. So that's the first one, I would say, and the most common and the most popular. And then there are problems with organizing skills, planning. So, for example, somebody who's working, they may have mistakes at work, and be late on time for their assignments and stuff like that. So missing deadlines, change in personality. Certain types of dementia, they manifest with change in the personality. So, for example, somebody who's been very outgoing suddenly becomes inert, very apathetic, not interacting, and that may be misdiagnosed for depression. So a lot of times people get treated for depression because the symptoms, they manifest as somebody who's depressed. Then later on, having problems with language ability, word finding difficulties, not able to recall names of people or objects, day-to-day objects in the house, or not recognizing familiar people by face. So those sort of things, making mistakes in the, financial planning and stuff like that. So it's a raft of brain function which is affected. And not everybody will have all of these symptoms in one go. It may manifest over a period of time. And certain types of dementia affect certain brain functions more than the others. But as a whole, in a broad nutshell, it is brain dysfunction. That's what I would summarize that as.
Got it. Thank you. That's actually a great explanation, because at Ivory, we are always trying to increase awareness. And I'm again interested in something you just said about how by the time people come to you, it's already too late. So let's say some family out there who's watching this, what would your advice be so that, they can proactively take some steps? What do you think an average middle-class family can do today so that it doesn't become too late by the time they come to you?
Yeah, that's again a wonderful question, because here something that can, or what we say is prevention is better than cure, because as we know, there's no cure for dementia. There are lots of treatments available, but cure per se is not there. So when you ask about prevention, it is basically healthy living is healthy aging, I would say. And certain things that we all read about, but we fail to do in our day-to-day busy schedule is, having this common sense approaches, which is, healthy diet, eating on time, not skipping a meal, looking after your blood pressure, diabetes, for that reason, getting your physical health checked up every so often, whether it is blood pressure, diabetes, quitting smoking, reducing the amount of alcohol one consumes, having a healthy, 6 to 8 hours of sleep, restful and relaxing sleep. There's a lot of emphasis now on sleep medicine and its effect on cognition and learning. So, getting that 6 to 8 hours, I mean, that's a broad term. Some people are refreshed with 6 hours, some need longer, but the average is 6 to 8 hours, that restful sleep. Leading a stressful life is another one, because, stress is so common. We cannot do without stress nowadays. So, leading a stressful life, stress-free life by yoga, meditation, socialization is another great one. And we realize the effect, aftermath of COVID, that how we all suffered for those 2 years. But socialization is something which has a protective factor, so that's part of the, stress-free life, I would say. Taking exercise, I cannot overemphasize that. At least 30 minutes of, or 5 times a week. So research says 150 minutes in the whole week. So you can have an extra, lie down in the bed for say a Saturday or a Sunday, but one day you're excused. But 5 to 6 days out of the 7, it's very, very important. And that can be a brisk walk, it could be aerobics, it could be Zumba, and so on and so forth. You can choose, or a swimming, or a game of squash.
Got it. You began your response by saying that there is no cure for dementia. There is so much of medical research happening in so many like hard medical conditions. Why aren't pharma companies able to come up with a cure for dementia? Is something on the anvil already? Anything that you can share?
Yeah, there's a lot of research. If you ask me, there are more than 200 to 300 molecules which have been researched. And as you know, Alzheimer's, which was first, invented about more than 100 years ago, but only 4 molecules have stood the test of time. So it's not an easy disease per se to treat, because it affects the brain cells and so on. So a lot of research has been carried out, for one molecule to go through the rigors of all the medical authorities, it takes a lot of time. So we may read or hear about some molecule, some breakthrough happened in the newspaper, say 5 years ago, and we don't hear it for another 10 years. Because of all these reasons, they have to go through various trials and safety protocols. So unfortunately, some promising molecules have failed because of their effect on the other, organs of the body. So some side effects which can be, worse than the dementia itself. Some which need IV medications. So imagine for a 70 or 80-year-old, you have to give them IV every so often. It's not easy. So there are some practical difficulties, but there is a lot of research being carried out. Some people liken dementia to the cancer of the mind. So we are already seeing a lot of breakthrough in the cancer surgery, various types of cancer, some more than the others. So hopefully, fingers crossed, we should be able to see some major breakthrough in the next few years. They've also tried vaccines and stuff like that. Again, it has not worked favorably. So we have to watch the space.
Got it. Reflecting on your extensive training and work in the UK, what are some of the differences in approaches that you have seen in terms of how health system works with dementia patients here and there? Is there something we can learn from them?
That's a very important point, because you see, the resources are somewhat more over there. It's not that we don't have manpower. In fact, a lot of people who work there are from overseas. Most of them are Indians. So resources in terms of, the financial, yes, we are a little bit thin on that. But, what works wonderfully well is our Indian culture, the joint family system, that we do look after our dear ones. Unlike over there, there are lots of care homes, or nursing homes. When they are not able to look after, they go over there. But unlike our culture, I think it will be taken as a failure if the son or daughter or the in-laws, daughter-in-law, son-in-law have to, So that is one thing. The protective and the socialization is something, it's an advantage for us. But what other things they have very beautifully done is, everything is so segregated over there. A lot of protocols that they follow. They have something, like tracking system, say something called as a telecare. So if the person wears the band, like a wristband, and if they were to wander in the middle of the night, then it will be tracked, and there will be a call center, call made to the family and everything. And, in no time, there will be an ambulance or a police, depending on the situation. So I think those things we have to learn a lot. Community support per se, we have the community, but we do not have the same. For example, we used to have things like community psychiatric nurse who would monitor the person, once they see a doctor, and there's a hell of a long waiting list to see a doctor. Unlike here, you can. So medical system per se, we have easy accessibility. So there are some differences over there, some positive, some negative that we can learn from. So yeah, and I think the prescribing bit, is slightly more common here. So people get lots of meds, thrown at them, which sometimes can be counterproductive, or in fact for the elderly population, de-prescribing or lessening the prescribed medication, only give them what is necessary, that we have to learn from them.
Got it. You spoke a little bit about this aspect of community support. Could you touch a little bit about that, especially because India is also going through a phase where nuclear families are also on the rise, right? And we are seeing more and more people go abroad for studies or career, etc., and parents are left at home. Does social isolation, or let's say an individual family unit, when people live alone, are they more at risk of developing dementia?
Yes, that is one of the risk factors. So social isolation, not only for dementia per se, but for depression as well. And depression indirectly puts you at a higher risk of dementia. So you can see how it is all interrelated. So yes, social isolation, and you pointed that out because I see in my clinical practice a lot of children ringing for help, because they are abroad, they're working or whatever, and their seniors are here, their folks are here. So there's something called as daycare center, which are cropping up now, even in a busy city like Mumbai, because it's. I mean, I compare that with like how you have a nursery for a toddler, where you have, say, AM session, PM session. You can have those 3 hours. You send them there. They do their learning. They come back home, say, for lunch, or they go there after lunch. So something like that is happening here, which is very promising. So that's what we call as day center or community center. So that will take care of your isolation. And there, in fact, we had started one such in Mumbai, but unfortunately, because of COVID, it had to be shut down. But everything was under one roof. So something what we call as memory cafe, a yoga group, a dance group, music group, art therapy, craft therapy, everything. I mean, and we would have a specialist, a trained professional for each one, catering to the needs of seniors. So that will take care of your socialization and social isolation. Plus, all these other therapies that we talked about, they are established form of therapies for dementia as well, and depression. So music therapy, dance therapy, we very well know, the whole world knows the importance of yoga, our ancient, science. So that was part of it. Art therapy, craft therapy, and something what we call as reminiscence therapy. So what that basically means is that, you have your old memories being jogged upon. So if you have a black and white album in the house, and you could ask, say your seniors that, Mama, can you point out, where is my picture, or where was this taken? So you will see that that's part of the long-term memory that will be crystal clear in their head, because that's how the dementia manifests. But unfortunately, with the progression, even the long-term memory is taken away in this serious illness. But these are various forms of therapy which are very, very effective. They're simple yet effective, which we can, do that in our day-to-day, in the busy schedule as well.
Got it. You've seen so many cases over your past 2 decades of experience. From your experience, could you confidently tell a dementia patient that their condition could be reversed, or it's very hard to say, or is it just about management of the condition?
See, when we talk about reversible and irreversible causes, there are some which are promising, or what we call as reversible causes of dementia. So, for example, when you go to a specialist, they would do your blood test, X-ray, ECG, brain scan, and there's a good rationale behind doing that, because what that physician is trying to do is pick out those reversible causes. So for example, underactive thyroid, or what we call as hypothyroidism, vitamin B12 deficiency, vitamin D deficiency, these are all the reversible. And some people drink excessive alcohol. So there's a very well documented condition called alcohol-related brain damage, or alcohol dementia for short. So once somebody quits alcohol, the further damage is prevented. unfortunately, whatever damage has happened may not be, corrected, but there is a lot of scope for improvement. So these are what we call as reversible. So when somebody comes to us during our 60 to 90 minutes first assessment, is what we are trying to siphon out is these cases, because you want to treat whatever is treatable. And Alzheimer's disease, dementia or Alzheimer's dementia basically is a diagnosis by exclusion. So what we are trying to do is exclude whatever we can treat and whatever we can reverse. So that's the whole idea. So few people, yes, we can say, because sometimes depression, as I said earlier, can manifest as dementia, and it's a treatable risk factor. So when we do the assessment, we are also trying to identify people who may have depression, and once we treat that depression, there is so-called cognitive impairment of depression, or pseudo dementia in olden days it used to be called, can be reversed, and you will see, or the family member will see, that now their memories come back, or they are much better. So that's the rewarding thing as a doctor for us.
What's the difference between neuropsychology and neuropsychiatry?
Okay, so that's a very common question we get asked, because see, neuro or psychology, let's do it this way: psychology and psychiatry. Because psychology is a science of studying the emotions and mode and stuff like that, and various coping mechanisms. When we talk about neuropsychology, it is identifying all the brain functions, for example, memory, language ability, reading, writing, comprehension. So all those different, and typically a neuropsychologist would be testing for these various brain functions. So the frontal lobe, for example, which is responsible for organizing, planning, when they're doing dedicated, cognitive testing for the frontal lobe, they will emphasize on that. So it's a highly specialized science. So that's the neuropsychological aspect. And then there are effects of all the other brain disorders on the brain. Say, for example, stroke, road traffic accident, Parkinson's, alcohol, and stuff like that. So neuropsychologists will be able to do that kind of work, and neuro rehab along with that. So, and when we talk about a neuropsychiatrist, so I trained as a neuropsychiatrist as well in the UK. Apart from geriatric psychiatry, that was one of my special interests, neuropsychiatry, because all these brain disorders, for example, motor neuron disease, multiple sclerosis, Parkinson's, stroke, and the others which I covered earlier, they will have, effect on the mental health per se. So on the mood, on the, depression, memory, and so on. Some people can get psychosis, which is very much similar like a schizophrenia. So those are things that we focus mainly on. So that's how, I developed interest into that, because, it is a bit of medicine as well, if you know, a bit of neurology and a bit of psychiatry as well. And it helps you to liaise with the neurologist and the geriatric specialist with your knowledge of psychiatry. So that caters, and we in UK we have a specialist team, and so you are part of that team. You do the ward rounds with those specialists. So it feels very much like you're back in the hospital as a doctor, whereas as a psychiatrist we are mainly in the clinic, or dealing with mentally unwell people, having emotional difficulties and so on. So that's how I developed my personal interest into that.
Got it. And in the typical life journey of a patient who's been diagnosed, where does your journey begin with regard to rehab for a patient? Is it at the very early stage? Is it at diagnosis stage, post-diagnosis? Could you talk us a little bit about that?
Yeah. So it could be right from day one, when a person comes to us and we identify what they're going through. So that could be like a fresh new patient. Or it could be much later on when, you get a second referral or a third opinion and things like that. But at every stage, we can contribute in different ways and means, whether it is just, the do's or the don'ts, even those are very, very important. then signposting them to appropriate services or the appropriate therapist, for example, speech and language therapist, occupational therapist, physiotherapist, music therapist, yoga. There's so much to offer. So a doctor doesn't mean that, you're just writing a prescription. It's also important where you should send the patient at what time, or where you should not send them, or it's of not much use, or it's not going to add to the outcome to the patient. So we liaise with the intensivist, for example, in the ICU on day-to-day basis, depending on the needs.
You spoke about tests when people come in. So typically, when, let's say, somebody who is thinking that he or she has got like a serious memory condition, what are the kind of tests that are available in India or that you use to help detect?
Yeah, so this is more for our audience, the lay people. So when you go to the doctor, I talked about 60 to 90 minutes. That's the minimum that we offer. Sometimes it can be longer. So we take a detailed history, detailed analysis of how the symptoms started, because a lot of things, a lot of illnesses we can identify, and then focus on those aspects more in depth. So the history taking, so from the patient or the service user or the client themselves, and then asking pertinent questions from the family member or their family friend, whoever is available, because we have to look for so many different sources. It could be a family doctor, it could be some friend who's not even in Mumbai, or out of city or out of country, because they will add so much. So it can take a lot of time, several assessments, if you ask me personally, to come to a definite kind of a diagnosis or differential diagnoses. So we would have 3-4 different possibilities, or some kind of a conclusion. So the history itself is very, very important. Then history of the medical illness, so comorbids, blood pressure, diabetes, what medications they are on, when was the last blood test, X-ray, ECG. Because if we want to decide about the medication, we need to look at the physical health profile as well. Then asking for pertinent scans, say for example brain scans. So there are several different brain scans which look at the structure. Some of them look at the function of the brain. Nowadays there are amyloid scans, but they are not unfortunately available in India yet. They're only for research purposes. Then we ask for this neuropsychological testing, which will have, as I said earlier, specific to each lobe of the brains.
Dr. Santosh, what are the most difficult challenges you face or India faces in diagnosing and detection of dementia today?
Yeah, because our sheer population and according to the research and the census, what we know is that we are heading towards what we call as a silver tsunami. So in by 2050, the number of senior population is going to almost be double, and the amount of people who are going to get these syndromes of dementia is going to almost triple. So that's something that is worrying us, and I don't think we are prepared, or the world is prepared. It's not only about India; it's a global challenge or a global burden, I would say, because it's the incidence, all the prevalence is almost similar with some variations in every region. But we are all heading towards that. I think a lot of publicity or research is diverted in treatment of hypertension or blood pressure, diabetes, and cancer. But when we talk about mental health, because dementia does have the mental health component, so it's like a Cinderella faculty. So not many people are, very keen, but it affects, I would say, 3 generations. So it's high time that we take it very seriously, and there are things which we can do to prevent it. We cannot, of course, cure it, as we know from our talk, that there are certain things we can do to prevent it, but cure is far away.
Got it. And can you throw some light on the importance of sleep? And because, we have continuously seen that a lot of people, like we were discussing a little earlier, are aware of the effect of bad things like sugar or excess alcohol, but not enough people seem to know about sleep. what exactly happens to the brain when we are sleeping, and why is it great for us to have sleep for better brain health?
Yeah, so sleep, I would say that it's a center or the main source of getting our for the whole body, physical health and mental health. So it's a main center. So if you and we all have gone through this. If you have a very bad night, or if you have slept late or got up early for a flight or something like that, the next day we feel very, very hungover or like a zombie, not very energetic. So that happens. The importance is because during that 6 to 8 hours of your sleep, and the timing is also important. It doesn't mean that you have your 6 to 8 hours say in the afternoon, and you cannot catch up for the previous night's loss. So it must happen between that 11 to say 7 or 12 to 8 or whatever the timing may be in those hours. Because there are two different types of sleep: REM sleep, or it stands for rapid eye movement sleep, or non-rapid eye movement sleep, NREM sleep. So the REM sleep is the most important as far as memory and cognition goes, because all the cleansing of the brain happens at that time. So imagine that you put your iPhone and it's getting updated, or it's getting charged. So it's a similar analogy. Second thing is the consolidation of memory happens during that time. So if you have disturbed sleep, your memory, whatever you read or learn, will not happen. So, in our college days, we used to have that, you'll sit the whole night to study, and before the exam, cram up everything, but very few things you'll remember, the next morning, the day of the exam. And there are certain disorders. One of that is called obstructive sleep apnea, or snoring is one of the characteristic symptoms without which you cannot diagnose sleep apnea. So it's a very common condition, but in our culture, we feel that, if somebody is snoring, that means they are getting a good night's sleep. Do not disturb them. But when you snore and it obstructs the windpipe, the oxygen is cut off to the whole body. And you may wake up with a like that. And that can be an observed spell of apnea. Apnea means cut off of oxygen, complete, zero oxygen. So it may be either witnessed, or by doing a simple, what we call a sleep study or a home sleep analysis, we can pick it up. The effect is on the whole body. Most, we'll talk about the brain here, is, it can put you at a higher risk of, A is depressions, 2 is, dementia as well. So a lot of research now on sleep apnea and its effect on cognitive impairment, dementia. And the second part is what we call as REM sleep behavior disorder, or RBD, or so it is something as people with neurodegenerative disorder like Parkinson, motor neuron disease. They can have this RBD much before they have the tremors and everything. So decades before. So it's like an harbinger for later life. So what basically happens is you get bad dreams or nightmares, and you act out those dreams. And this is classical between 2 to 4 a.m. in the morning. So you'll be fighting out the dreams, and you may not recall that very well. And the common theme is that you've been chased, or your family is in danger. Say, for example, you're meeting with an accident, and so these are the basic, the common themes. So the bed partner may get hurt because you're fighting out the dream. So that's something we have to look for. So these are the two things I would say, that sleep apnea and REM sleep behavior disorder. So when we talk to our patients, this is about the prevention, is sleep hygiene, getting that 6 to 8 hours of sleep. So avoiding drinking coffee or caffeinated drinks after 4 o'clock, because it will affect your sleep. Avoiding a late night meal or a heavy meal. So classic thing is, you eat much earlier during the evening, have a light dinner, do not drink alcohol, quit smoking, because smoking is a stimulant, itself. So you'll not get a good night's sleep. Now having a lukewarm water shower or a glass of milk can also help. promote sleep, listening to soothing music as opposed to reading. You could reading from the iPad, because those blue rays are toxic, as we all know. So reading from a good old newspaper or a book is always good. Soothing music, as I said, can be very, very relaxing to the brain. So effect of sleep is not only on dementia or the prevention, but also for depression, anxiety, so on and so forth. And blood pressure and diabetes. I forgot that. Sorry.
Got it. Yeah, please continue.
Yeah. So those are the things which are the indirect risk factors for later life dementia.
Got it. Dr. Santosh, it was wonderful chatting with you. You shared so many of your insights from your rich experience. Before we end, I want to ask you, if somebody is just been diagnosed, somebody's family has just been diagnosed with having a dementia patient under their household, what is your one message of hope for them?
The hope is, I think we are all in this. It's a very common condition. So accepting that, the awareness that, yes, this is something which is there, and not blaming them for their sort of whatever behavior they are manifesting. So bringing them forward to help is the most important thing. Accepting, having that awareness, not, suffering in silence, because there's a lot of stigma, if you go to a psychiatrist or another professional from the field. So it should not be looked upon with that kind of an attitude. There is lots more that we can offer and support. Nowadays the emphasis is living well with dementia. There are a lot of things that we can do to support our near ones and dear ones. So it's not all doom and gloom. It's adding the quality of life, to your family member. So that's the most important thing.
Got it. Thank you so much, Dr.
Pleasure.
Santosh.
Absolutely.
It was wonderful chatting with you. Thank you.
Thanks.